views, information, or opinions expressed during AAOA broadcast series are solely those of the individuals involved and do not necessarily represent those of the American Academy of Allergic Allergy, its employees, or members. The AAOA is not responsible and does not verify for accuracy any of the information contained in and assumes no liability for any activities in connection with these broadcasts. The primary purpose of this broadcast series is to educate and inform and does not constitute medical or other professional advice or services. Advertising which is incorporated into, placed in associate with, or targeted toward the content of this product without express approval and acknowledgement of the AAOA is forbidden. These broadcasts are available for private, non-commercial use only and may not be edited or modified from their original form or reproduced for distribution.
So welcome everybody to our Zoom recording of managing the allergy patient in the COVID era. And I'm joined by several distinct panelists here, and we'll just kind of go around the Zoom squares introducing ourselves, if that's okay, starting with Dr. Michael Platt.
How are you doing? I'm Michael Platt. I'm from Boston, Massachusetts.
Hello, my name is Michael Parker. I'm from Syracuse, New York, and have been in practice for a decade or two, and enjoy the opportunity to share some experiences during this challenging time.
Hi, I'm Cecelia Damask. I'm in private practice in the greater Orlando area, and I appreciate your invitation to speak tonight.
Yeah, absolutely. And just to get it out of the way, does anyone have any conflicts of interest that they would like to disclose at this time? Because we can go around the same Zoom squares.
I am a consultant for a company called GI Reviewers that reads blinded research studies for polyp biologics. Dr. Parker?
I am on the speaker bureau for Optinose.
For ALK, I'm on the advisory board. For AstraZeneca, I'm a speaker and on the speakers bureau. For Audigy Medical, I'm a consultant. For Genentech and Novartis, I'm on their advisory board. For GSK, I'm on their Speakers Bureau advisory board and also did contracted clinical research with them. Oh, I forgot, I also did contracted clinical research for AstraZeneca. I'm on the Speakers Bureau and also did contracted clinical research for Optinose, and I'm on the advisory board and Speakers Bureau for Sanofi Regeneron.
All right. Well, with that, we will kind of start diving right in here. And one topic that I have heard a lot of questions about and have some of my own as well is that a lot of what is being discussed in terms of what to do with management of the allergic patient is that it should be an individualized decision. And so within the understanding that all of our patients are different and some people are exiting their allergy season, some people are entering, some have asthma, some don't, do you have any quote unquote best practices that you're currently following? And is there any evidence to back up what you're doing, or is it more based on clinical experience? So maybe starting with Dr. Parker.
That's a great place to start, and recognizing that every patient brings their own story, their own potential for concern. So we want to be safe as we manage our patients during this unusual time of a pandemic. We don't want to, if we can continue to manage their allergic disease while not putting them at greater risk of some other problem or additional dilemma related to COVID, right? That's at the top of our list. So that thought goes into every patient we manage.
Dr. Damask, do you have any personal best practices that you're adhering to, and what's informing them?
Sure. So I did look to several resources to help me decide what I wanted to do with my practice. One is called the Pandemic Contingency Planning for Allergy and Immunology Clinic. This was published by the Quad AI and is in Jackie in practice. Then also the Quad AI, they have a work group for their immunotherapy, allergen standardization, and allergy diagnostics. And they also put out guidance. And then thirdly, I also have been following the practice parameters and their guidance in terms of immunotherapy.
Anything surprising in there, or anything that you didn't expect in terms of the guidance?
No, I mean, really, most of it was pretty common sense and what I thought I was going to do anyway, but I found it reassuring that at least I was on the same wavelength as those experts.
And Dr. Platt, what about you? Any best practices or any kind of more standard recommendations for whatever is your standard allergy patient?
Well, currently my practice is completely shut down by the institution. And so I'm not really following any best practices as we speak, but I am planning for reopening. And I think that the references that Dr. Damask cited there are the ones that I also use that I'm using for opening, because really the common theme through all of that is basically safety, patient safety. And getting back to your initial question about the individual patient, I think that just the nature of the practice of allergy, how sensitive someone is, what time of year it is, where the comorbidities, these are the factors that you take into account when you formulate a plan from the beginning. And so now that I'm restarting this practice in the next, hopefully, few weeks, or who knows exactly when, but being safe, I think, is the underlying theme throughout all of these guidelines. And I think that they were really helpful for me, at least, to go through and be reminded of what are those safe practices and how can I help keep my patients safe through this time.
And so Doctors Parker and Damask, for patients that you were currently escalating on SCIT, what have you been doing for most of those individuals?
First of all, I think things are different depending on where you are in the country and what's going on in your individual community and circumstance. And so I do think things are going to be very different whether you're in Boston or New York City versus maybe someone who's in Wyoming. But for me, and even in the state of Florida, for me, very different what's going on in South Florida versus where I am in Central Florida. So for me, I did stay open to offer immunotherapy for our patients, as well as other services like essential services like biologics. But for immunotherapy, if they are an escalation patient, I kept them at whatever their dose was and tried to spread out the interval longer. And so I spread out their interval to every 2 weeks. And normally we have open hours for allergy and patients just come whenever allergy is open. Instead, we scheduled them, and we scheduled them according to how much space I had to be able to spread people out in the waiting room and throughout my office to be monitored by staff afterwards.
And what about you, Dr. Parker?
I'll reflect several of the same comments that Dr. Damask made, that we have sort of spread everyone's interval out. So if we were escalating you, we paused you at your dose. If you're weekly, we tried to move you to every 2 weeks. If you're every 2 weeks, we tried to move you to out by another week. So we're trying to space patients out while not losing some ground, right? We're trying to maintain the process of hey, here's this goal of trying to encourage your immune system to develop some resistance, some tolerance. How do we do that safely while we don't expose you to unnecessary risks of contact with other patients? So we've lessened density in the waiting room, done the similar things, try to find a time when we're not so busy to spread out that patient load so we can keep the density of patients at a minimum.
Great. And I know everyone is eager to, at some point in the future, TBD, to get our practices fully up and running again. As you think about restarting allergy immunotherapy, and especially you, Dr. Platt, since you are kind of at a standstill in general, what kind of things are going through your mind as you're making that individualized decision as to where to restart patients who previously were in the escalation phase of immunotherapy, in terms of backing off a dilution, vial testing for safety, et cetera?
Right. So I think that everyone's going to have an individual plan. I'm going to sit down with my allergy nurse and formulate that. And the factors are, how long have they been off of their injections? And the further off they've been, the more I'm going to back them off. And so I'm expecting that maybe it's going to be a month, 2 months, 3 months, and then they're definitely going to get backed down depending on how long it's been. And then the other thing is that you mentioned a vial test. I think that vial test is always safe when you're starting off again or starting a new vial. There's no loss, no harm in doing a vial test. And so for sure, I'll be doing vial tests. And then the other factors in terms of the individual patients, how sensitive they are, things like, do they have asthma and is it controlled? Have they ever had a bad reaction? What time of year is it? How healthy are they? Their overall how allergic they are in terms of their history. I think those are all factors we'll consider in terms of how far we back them off and then how quickly we'll re-escalate them.
Any other thoughts, Dr. Damask or Dr. Parker?
I agree. I mean, I think that you definitely want to be safe, and when making a decision, it's always best to err on the side of safety during these times, and always with immunotherapy.
I agree as well. You know, we have a little bit of wiggle room, and so yeah, try to do this safely.
And one question that I've had from a number of my own allergy patients, especially the ones that do also have asthma, is what are you telling your patients when they're asking you, am I high risk? And how worried do I need to be about coronavirus?
Despite maybe what is out there in the PSAs, there is really relatively little data at this time to show a specific increased risk in asthmatics or an increased disease pathology in asthma patients who are infected with COVID. When you actually look at some of the data that's been coming out, especially out of China, asthma was really not a strong risk factor for severe COVID-19 disease. Also the same in terms of data coming out of Korea. It also suggested that asthma was not even a relevant comorbidity. So I think our asthmatic patients have more of a risk this time of year of having an exacerbation if their asthma is not controlled from just increased allergies this time of year than actually having problems with COVID-19.
I think that's fair enough. One reason I think we're all going to get more of these questions is there was just a CNN article that literally says asthma and your risk of coronavirus, you know, implying that there is that increased risk. I think the underlying principle, as always, is we want to make sure that those patients are as optimized as possible on their asthma routines. And I think that leads into some of the other patient concerns regarding everything that's floating around in steroids. Am I more at risk? Am I better off not taking my inhaled steroids? What about if I sometimes require oral steroids? So maybe Dr. Parker and Platt, if you could comment on those specific steroid-related concerns and how you explain that to patients.
And so the conversation I would have would be, hey, if we need the steroids to manage your asthma, we don't want to let your asthma get out of control. That might ultimately require even bigger doses of steroids to get you back under control. And that potentially could put you at risk if you were to become infected. So here's a manageable dose of steroids. Hopefully that keeps you out of trouble and we can stay the course.
I think that the guidelines that Dr. Damask referenced said that you should want to continue taking your inhaled and intranasal steroids to try to keep your airway healthy. And you're trying to prevent an exacerbation, which would lead to an ED visit or an inpatient hospitalization and more risk of exposure to people who have been in contact with COVID patients. And then if you happen to get infected with COVID, you want your airway to be optimized. And so the inhaled steroids, I think for sure, should just be continued. And then there's that question of oral steroids. And there is data that show that if you happen to get a COVID infection, it is detrimental to be on oral steroids. It can result in a worse infection. Sometimes they're used later on in the disease when people have more severe lung problems, but early on it's to be avoided. And so that conversation with the patient of whether they should take a short burst of oral steroids for an exacerbation should probably include discussion of those risks that if you happen to get infected. And I think it's also meaningful so that the patients who choose to take it will know that they must completely isolate and make sure that they don't place themselves in any additional risk if they're going to be on oral steroids. They do not want to have a COVID infection, but it is definitely something that you can and should provide to the patients to keep them out of the ED, keep their airway healthy, prevent further exposures.
And then as we think about our practices becoming more open or some of the restrictions lifted, what is, because for us, we're allowed to see quote unquote urgent patients, but I think that, there's always clinical discretion there with any decision, as there should be. But who initially defined those urgent allergy patients that you would want to continue seeing? I know Dr. Damask, you alluded to some of your, not just injection patients, but then also biologic patients as well. So I was hoping to hear from the group, how are you defining what's truly urgent in the allergy plus minus asthma practice? And then how are you justifying those decisions if that's required?
So if I can talk about testing a little bit, right? So we're still, we're in terms of prioritizing patients in terms of urgent versus non-urgent and things we might do. We're not doing any new patient skin testing right now, even though the patient may have significant symptomatology. And in the current setting, we may opt for in vitro test or in vivo testing, draw some blood and do an in vitro tests, and try to manage the patient with that information versus skin testing, recognizing this, just the time and the exposure of the patient in the office during skin testing may increase the risk. So an example of a modification of our practice based on the current setting.
I think more than ENT wise, I think that allergy type of patients lend themselves really nicely to telemedicine visits, because in terms of allergy, there are very few things that I can't at least talk to a patient through a synchronous audio and visual platform and see what's going on. Whereas with ear, nose, and throat type of stuff, it's very difficult for us to look inside their mouth, look inside their ears, look at their larynx, things like that. With a telemedicine visit. However, the one exception, and someone that I would definitely want to see in my office, are some of my really severe asthmatics who might have very poor self-perception of how bad their airflow limitation may be when they're having something like an exacerbation, and might not really be able to tell me how they're doing, how they're feeling. And those are the type of patients that I really would want to see in the office and be able to listen to their lungs, because I don't have attachments for my telemedicine where I can remotely listen to their lungs like some university settings can.
Actually, I agree. I think, to talk about allergy management via telemedicine, it works for a large number of patients. Right? Probably in that acute asthmatic setting, maybe we lose a little ground, and testing or monitoring pulmonary function falls apart a little bit in this current setting as well. But for the patient who's doing well, to continue to monitor them, the telemedicine visit seems to be working. And maybe a paradigm for the future, who knows, right?
Yeah.
Dr. Platt, do you have an idea of who your highest priority when you're allowed to start seeing patients again, patients will be?
Yeah, that's a good question. I'm in a busy academic ENT head and neck practice, and they've asked us to prioritize things like our surgeries and patients, and it's difficult because the vast majority of my patients have chronic sinusitis, allergic rhinitis, and it's really quality of life treatment that I'm doing. And I'm, sharing space with my colleagues who have head and neck cancer and airway obstruction from subglottic stenosis and mastoiditis and more, what I would think is dangerous, life-threatening disorders than quality of life. And so I'm probably not first in line for getting things in the clinic, which is okay. I have been doing a lot of telemedicine visits, and I do think that my patients do lend themselves well to that. Eventually, though, I'm patient, and I think that the opportunities will, when we figure out how to do this safely, I'll be back and up and running, hopefully full speed, as long as we can keep everyone safe.
And then as we think about going forward, recognizing that probably things are never going to go back to quote unquote normal as they were before, is there anything that you've learned in terms of changing your practice paradigm or the way that certain patients are managed that you will plan to continue to implement in the future?
So one of the things most definitely that it has made me very self-aware, and Dr. Parker and I actually talked about this, is how very little PPE I used to actually use with all the patients that I saw. And we're up in people's faces, up in their ears, and I really did not use very much PPE. Whereas when I would go to the dentist, and they arguably are just as much in people's faces as we are, they are head to toe. You know, they have on their isolation gowns, they have on their goggles, they wear a mask. And now when I think about it, I really probably should have been doing the same all along. And that probably will change for me going forward.
Yeah, we all kind of have taken historically not our own safety for granted, but yeah, again, compared to the dentist, maybe we could have done a better job protecting ourselves. And today, I think we're all a little more aware and trying to be as cautious as we can be. Yeah, no question.
Yeah, I agree. I really took it for granted how every other patient, I would just use a scope. I think it's essential to know what's going on in the nose of my patients, to look, and I just took it for granted. You know, put a glove on and that's it, you just fly. And it totally has changed. It will never be the same. And now the challenge is how do we do this safely at the same volume that we did it before? I don't know what the answer is. You know, I saw one urgent patient last week, and Dr. Blyer had a nice article where he wrote about using a mask on the patient with a small diaphragm, and I tried that. It was a little cumbersome, but it did work. But you know, even after you take out the scope, is that safe then to just have the scope in the room? You know, I think that we're all looking for that new type of technique, PPE, and I think everyone is going to be searching for how do we get back to just being able to look in noses again as we did before without any risks.
Is anyone planning to continue to do telemedicine? Probably not to the same extent that you're doing now, but as an adjunct now that you've seen how patients have reacted to it, et cetera. And kind of similar question for other workarounds, such as, you know, we're doing drive-through allergy injections for those already on maintenance to avoid the exposure of coming in. And, you know, similar to what Dr. Francis was mentioning on the ARS podcast, you know, having a system in place for patients to be observed safely, et cetera. It's one of those, would that ever have happened not during the COVID era? No, probably not. Is that something valuable to potentially consider going forward? I don't know, but I'm interested to hear your perspectives.
You know, anytime you're exposed to adversity, humans get creative and figure out a way to solve their problems. And so collectively, here we are during this pandemic, trying to continue to care for our patients. And some creativity is bubbling to the surface, whether that's in the monitoring of our patients post-injection or you know, again, somehow creating a setting that lessens their risk. So it's kind of fun to talk about it as we watch it happen around us, right? Interesting.
Yeah, but I think for sure it's here to stay. You know, there's some advantages to it, and I work at a safety net hospital. I have some patients who have a very difficult time getting to the doctor, and they get referred from, you know, an hour and a half away, 3 buses and a train, and they walk a mile. And I do an allergy evaluation, which is the majority of which is a history. And then I ask them if they can come back to have allergy testing because we don't have point of service testing. And it's a huge burden for my patients, but this is an opportunity where I think there's so many things that we can do to treat patients with telemedicine. And I even had a discussion with my chair this week who said this is definitely here to stay. There are definite advantages, and I don't think it's going anywhere.
And as we start to wrap up, if there was one take home or takeaway message that you would want whoever's listening or watching to get from this experience with us, what would your one take home be?
So for me, the take home message is whenever and whatever you are doing to think about restarting and re-engaging with patients, above all, you want to be safe. And I really encourage you to think back to your education and training that you have gotten from your wonderful AAOA courses, where above all, we really stress safety. And just think back to the training and education that we've provided you, and the importance of safety that we've always stressed during those courses.
I'll echo those comments that right at the end of the day, we want to take good care of our patients, and to do that well, we need to be cautious. If they've missed doses, we need to back off. We need to minimize their social interaction in the office setting. All those things that again, we're all participating with. It's an interesting time. We'll look back on it and scratch our heads and wonder if we did everything we needed to do. And hopefully the answer is yes. As we learn how to handle these pandemics, hopefully we don't get to see another one for some time.
Yes, and I'll agree and say that, patient safety is our primary concern. And I think that the other half to that is keeping our staff and ourselves safe. I have a colleague, an ENT physician in town, who was in the ICU with a COVID infection, and his family is infected, and it's pretty scary. And even though we all wear PPE, there's always times when you could be exposed. Oftentimes it's when you're taking off your PPE, you don't realize you can get contaminating. And then just the fact of doing surgery, people are being intubated, they're being extubated, patients are coughing, patients are bleeding. And I don't think that we realized what a high risk specialty we are. And so being safe is, keeping the patient safe, but also keeping ourselves safe, which in turn keeps our family safe, as well as our staff. We have a huge staff, a wonderful staff, who helps us with patients, with rooming, with cleaning rooms, with moving patients around, with caring for patients in lots of different ways, and things we do, where we put our scopes, how we put our scopes, really have a big impact upon everyone in the clinic. And so it's really our responsibility to figure out, how do we do this safely? We all went into this field because we love this field. We never thought about this is the most dangerous field to be in right now. And so times have changed, and we'll adapt and we'll figure it out. And so when I see and hear about practices in areas where they've had high cases and they're reopening and they're making announcements, and it always just makes me a little concerned about, we all have those pressures and no one knows what the right answer is, but just keep in mind, how do we keep others safe? The last thing we want to do is hurt our family or our staff.
Yeah, I think those are wonderful parting thoughts. It's like, be safe in terms of the patients, back them off, de-escalate, make it clear why that's occurring, and then doing everything we can to protect ourselves and our staff, and by extension, our communities. Well, thank you so much, all of you, for your time tonight.
Thank you.
Thanks for asking.
The opportunity.
Thanks for the invitation.